So thank you for the organizers for inviting me, or to the organizers for inviting me. So we are, as transplanters, always the last resort, and you just heard from Dr. Allen that only 10 to 15% of patients ever are eligible for what we do, and I disagree with that. Only 10 to 15% of patients ever get sent to us, but a lot more should be sent to us. I think many more patients would qualify and would benefit. So let me try to make that point. How do I move here? So I'm going to talk about a couple of things. The role of transplant in CLL, and unfortunately, there's a difficulty there because all the data that I will show were accrued before we had all these exciting new drugs. So they all need to be reevaluated in the setting of Ibrutinib, Idelalisib, and so forth. And so there's some guesswork there. I will talk about what I call complicated CLLs. I don't have a better term, but I hope it'll show by itself what I mean. And I will talk a couple slides about Richter's transformation, but at risk of being overlapping with what Dr. Allen said here a second ago. So what have we learned about allo-transplant for CLL in the past decades? We know that, and I will show you a couple of slides to prove my point or to demonstrate my point, allo-transplant can cure people. And I think that remains an absolute statement that cannot be challenged by any other current therapy. And so I think if we can improve allotransplant, if we can incorporate it with other treatments, if we can make it safer, that could be an extremely, or could remain an extremely powerful tool. Second point is that, for better or worse, we've abandoned myeloablative conditioning. And I'm not going to go into that very much, but that's a debate that is over pretty much. Third point is that, and that is, the third point is, how do we select patients? We select patients because we think they are not going to tolerate it. So we worry about treatment-related mortality. And in the old days, we said treatment-related mortality, don't take anybody over the age of 40. Don't take anybody over the age of 50. Don't take, I'm talking to patients age 75 all the time in my clinic, and they do quite well. So age is a very poor predictor of outcome. There's many better predictors. We have to learn a lot about them, but comorbidities, functional status, much more important. Donor type used to be a major limitation, and no longer is. We can get donors for everybody. The cure rates indeed are better in patients in complete remission, but that's not an absolute. Some patients with active disease do get cured with allotransplant. And GVL effects play definitely a role in achievement and maintenance of CR, but that's a double-edged sword. We need to learn to get GVL effects without getting too much graft versus host disease, because chronic graft versus host disease, though it might somewhat prolong life, can also debilitate life or can be a huge burden. And then patients in complete remission for more than a year have an excellent outcome. So this is the point that donor type doesn't matter anymore. These are patients from my own institution, actually University of Chicago, where I was before, and at Cornell, comparing our cord blood transplant. These are not CLL patients. This is the only slide that is not restricted to CLL. These are mostly AML patients. But as you look, unrelated donor transplant, cord blood transplant, patients over the age of 50, this is restricted to patients over the age of 50, outcomes are quite remarkably the same. If I would show you treatment-related mortality, it would be for both groups around 20%, and another 30% of these acute leukemia patients will relapse. Now, these are many advanced patients. The point here being that I can find a donor, even if the patient doesn't have siblings, even if the patient is of an ethnic minority with strange HLA or unusual HLA types. And these are our data, but there's many, many other reports from other centers. What then about the outcomes of non-myeloablative transplant? Data from Isakuri at MD Anderson. Presented in 2011. Since then, he has some more updates, but I thought this was quite complete. So 86 patients. What kind of patients get transplanted by Isakuri? They're 58 years old. They're not selected to younger patients. They go from 36 to 70. They don't all have matched siblings. He's not going yet into the cord blood or haplo-identical transplants, but I can assure you this can be done. They are heavily pretreated, 62 months between the diagnosis on average, and sometimes 15 years or so after diagnosis. 20% have Richters. Most of them have marrow involvement, so they are on average not in remission at the time of transplant. They have high LDH in many cases. They have their worse prognosis in the sense that they have unmutated immunoglobulin gene. They have a quarter RP53 mutated, fludarabine resistant until recently the basis of transplantation, and many, a quarter, have low IgG and low CD4 counts, probably reflecting advanced disease and extensive prior treatment. Outcome in these 86 patients, long-term outcome. So overall survival of these patients is about 50–60%, and this is long follow-up. This is 4 years follow-up, 6 years follow-up, patients going out to 10 years. So I think this is quite compelling that these patients, despite failing multiple prior treatments, could be cured. I could show you better results probably if the patients were referred earlier. So I think a lot of patients can benefit from this. Progression-free survival is worse, but it's still at 40%. And the interesting thing is, again and again in allo-transplant, one sees an ability to successfully salvage patients who have relapse. It seems that the GVL effects remain. They remain even after relapse, and they enhance the effects of salvage treatments. What were the problems then? There was treatment-related mortality. At 1 year, 17% of the patients have died of complications. That is a horrendous number, I always think. That is low for transplant studies, but that is still a very toxic treatment. So one could make that better by referring the patients earlier. I think also over time, results have improved. Some of these patients were 10 years ago, but unfortunately, it remains the case that we lose patients every year that we don't expect to lose. And I think it can be reduced. It cannot, in 2015, be brought to zero. And this, to me, is the major problem. 60% of his patients had chronic graft-versus-host disease. And chronic graft-versus-host disease is something that many times persists and continues to bedevil patients and to bedevil their quality of life. And I think we need to learn to do better in that respect. But age doesn't matter. And low CD4, this is age doesn't matter. These are his patients over the age of 60 versus younger than 60, and age doesn't matter for outcome. Low CD4 and IgG really matters, showing that people who are really profoundly immune suppressed prior to transplant have a much worse outcome. And that is not surprising, but that's still a novel finding. Importantly, P53 or 17p abnormality doesn't matter. These are data from the Europeans. So relapse rates in patients with or without P53 abnormality exactly the same. 17 survival or progression-free survival, exactly the same, whether or not one is P53 mutated. And again, allo-transplant remains the only treatment for which this is true. So I think we have, in some respects, something better than CAR T cells. We have profound GVL effects, profound anti-tumoral effects, probably against a variety of tumor or tumor-associated antigens. And this is quite interesting. This is recent from MD Anderson, again, from Isa's group in a very good journal. And they looked at the P53 mutated patients. And I'm not showing you all the details, but what really happened was some of them were never referred to a transplanter, and some of them were. And they were about the same age. There were no significant differences in advance, in degree of disease, in where the disease really stood, in prognostic features. But the ones that were referred to a transplanter and underwent the transplant had a 60% survival, and the ones that didn't mostly died. So please be careful with this 10-15% can only be transplanted. Please send them to a transplanter and let them discuss with the transplanter, and let then the transplanter, together with the patient, together with the referring physician, decide on whether this is appropriate treatment. But please send them all our way and let us figure out whether there's a donor. Let us figure out whether there's an option. Don't decide this is not possible. I think that's depriving patients from a potentially curative therapy. GVL effects play a role in achievement of remission, again from Isa Khoury, MD Anderson, and from the Europeans. So what he saw is patients who have early observation of minimal residual disease that persists. He gave them DLIs, or he withdrew tacrolimus. He did an immune manipulation. Then they did quite well. The ones where no intervention was done did quite poorly. Similarly, in Germany, they followed minimal residual disease after transplant with a very non-myeloablative procedure. So a lot of the patients had detectable minimal residual disease. Some centers, this is multi-center, some centers opted to give those patients donor lymphocyte infusions, and those patients did quite well. Other centers didn't intervene on this minimal residual disease observation, and those patients mostly failed. So the immunologic effects of a transplant are quite powerful in CLL. They come at a cost, unfortunately, these days still, and I think that's where we have challenges. They come at the cost of graft versus host disease at times. Lastly, and I think this is for future design of protocols quite important, those in complete remission for more than a year have an excellent outcome. And again, I think these two slides come from the Europeans. They looked at patients who had detectable minimal residual disease at 12 months versus those who didn't at 12 months. If one did not have detectable minimal residual disease at 12 months, the beginning of the curve, one continued to do well for up to 9 years or so. And if one had minimal residual disease detected by flow, then one relapsed. So if we want to, I think this is quite encouraging. If we can get patients in remission for a year with a transplant, then we can perhaps safely say, listen, we are okay, we are cured, we don't have to do anything. So similarly, if they were MRD negative at 12 months, they rarely even became MRD positive. Not only did they not clinically relapse, but rarely did MRD positivity recur. And lastly, and Dr. Allen already showed that, after relapse, prolonged survival is possible. I won't dwell on these, but these are people who relapse, and these are the Richters, these are the non-Richters, so they have had an allo-transplant, they relapse, and still on average they live 5 years. So these are people who came to transplant for very advanced disease, then we did a transplant, and then we say the transplant failed. Yes, it failed, but it seems to make their disease more amenable to subsequent treatment. So the landscape has obviously dramatically changed in the last couple of years with all these wonderful drugs. But these drugs are not perfect. They don't rarely induce complete remissions. And you've probably seen this endlessly, but if one is 17p deleted, in particular, one tends to relapse again. And we've now seen data on transformation, so there are still people who don't do well even with these treatments. So who do we still transplant? I would say these patients failing BTK inhibitors, of which I have seen the first one last week, who progressed without transforming on BTK inhibitors. Patients with 17p abnormalities, I personally would still recommend to do a transplant, or to at least seriously consider a transplant, and to, for sure, look for donors for all of them. The complicated CLLs, and again, that's my term, but, and it's not a very good term, but it's the best that I can do. What do I mean? Two patients from Cornell, a 38-year-old gentleman, a 57-year-old gentleman with a lot of comorbidities, with no comorbidities, but both of them with a litany of prior treatments that none of which had really worked over 8 years, and here over about 4 years, and come to us profoundly pancytopenic, transfusion-dependent, iron overloaded, with in one for sure evidence of myelodysplasia, and in the other one a lot of debate between various opinionating physicians on whether this represented MDS versus pure red cell aplasia versus consequences of CLL. Be it as it may, both of these patients were quite ill, had active CLL, and were profoundly transfusion dependent and had actually a quite poor quality of life. And patient one was transplanted with our cord procedure now 3 years ago, 2.5 years ago. I won't dwell on that, but this is again, 10-15% can be transplanted. Not true. We found a cord for this gentleman. And he engrafted by day 15. He didn't have an easy time in the first half a year after transplant, but we are now 26 months, actually almost 27 months after transplant. He doesn't have graft versus host disease because cords rarely cause graft versus host disease. He has no CLL, he's back to work, he is a contributing member to our society and very successful gentleman. And all we are worried about right now is phlebotomizing him to get rid of the iron overload. And the other patient as well, we found an unrelated donor. Again, not eligible for transplant. He had multiple complications, comorbidities, surgeries, and so forth, but he did wonderfully. And he is also 38 months after transplant, and in him we now detect a little bit minimal residual disease, but he continues to do well. And last, so there's more and more heavily pretreated patients with marrow failure states, MDS, and so forth. We see those patients, and I think of transplant. And Richter's transformation, you've already seen this. If you get them into remission, they do quite well. And this is the last patient I'm quickly going to show you. 71-year-old male again, not a transplant candidate because he's too old. He has emphysema, he's too old, he has emphysema. And we work him up, and he has residual uptake. He's in remission of his large cell lymphoma that was of the same clonal origin as his CLL. But then we found that he had residual uptake in the lung, and we found that he had an adenocarcinoma in his lung. And which, as you heard, is not uncommon in CLL. People are at risk for. So all these contraindications for transplant, but this was curatively resected. And we transplanted him about 8 months ago, and he's in perfect shape. And he just went on vacation for 3 weeks to his cabin up in Maine. And so he's really enjoying his life. So with that, I think there continues to be A role for allotransplant, I would say, for people who fail first-line treatment, for patients who have MDS or marrow failure states or heavily pretreated patients with Richter's. Outcomes depend to a certain degree, but not absolutely, on disease response, probably on the degree of prior immune suppression. Very little, I wouldn't say not as an exaggeration, but very little on donor type and on age. I think our challenge is how to make this safer, how to maximize GVL, minimizing chronic GVH. Ibrutinib post-transplant is actually a very attractive agent in this setting because it probably mitigates graft versus host disease while reducing the risk of recurrence for CLL. With that, thank you very much.